A very good morning to all. My topic for today is IgG4 related disease. We will try to decode it from pathogenesis to the diagnosis. We begin this topic with some subheadings like introduction. I will be discussing about the subtypes of IgG, the subclasses of IgG1, G2, G3, and G4. And we will define the exact definition that is required to call IgG4 related disease that is proposed by the international guidelines currently. And we will see the epidemiology burden of the disease, the pathogenesis, then clinical manifestations, and the diagnostic criteria currently proposed, and the treatment modalities. So to begin with, a brief introduction about the 5 types of antibodies which we have. IgG constitutes the most common and the most abundant antibody in the body, and it accounts to 70 to 75% of all immunoglobulins in the blood and is responsible for long-term immune memory and the secondary immune response. The primary immune response is basically by the IgM, which is the initial antibody that is released after the antigen-presenting cells sensitize the lymphocytes. So the long-term memory cells, the long-term antibodies produced are the IgG. So while the IgA aligns the mucosal surfaces of the GIT, the respiratory tract, and they are also seen in the saliva. And these IgD is helpful for the release of IgM. So, and the last one, the IgE, is responsible for the allergic reactions, and it is seen in cases where there is parasitic infestations, and it binds to the mast cell and basophil and causes degranulation. So further subclassifying IgG, it has been subclassified into IgG1, G2, G3, and G4, depending upon the location of the disulfide bond and the hinge region. And also the functional difference also is there. The other forms, IgG1, G2, and G3, have shown to bind to specific antigens, and they have specific role in functioning. While the IgG4 currently the function is not clear, and the antigenic stimulation of IgG4 has not yet been documented. So what is IgG4? It is the least common subclass of IgG, constitutes 3 to 6% with uncertain function. It has low affinity for the target antigen. It does not activate complement. It is hypothesized that it acts as there is some role of this IgG4 in parasitic infestations and in allergic reactions as well. So that's why in allergic reactions and IgG4 related diseases, we are seeing slight increase in eosinophils. In IgG4 diseases also, we are seeing slight increase in eosinophil. So IgG4 is a non-inflammatory antibody, and as we can see here, the complement fixation and the activating FCG receptor binding domain are not present in IgG4. While researchers are currently, they are working on knowing the exact role of IgG4, and some of them have found that IgG4 in fact plays a negative role in lowering the inflammation. So now the research is going ahead towards knowing the role of IgG4 in lowering the inflammation query. They are labeling it as antigen sink. So the exact definition of IgG4 disease states that it is a systemic immune-mediated fibroinflammatory condition which manifests with chronic lymphoplasmacytic inflammation, demonstrating as increased IgG4 plasma cells and with storiform fibrosis. So the criteria here is there should be a mass-forming lesion or tumor-like lesion due to the formation of fibrosis. So it is an immune-mediated response, not documented as autoimmune. It is some kind of immune-mediated response that is going on, and there is increased proliferation of IgG4 specific antibodies. So it was the first case was described in 2003 by the Japanese researchers, and IgG4 related disease is not a new disease. Many previously recognized single and multiple organ involvement conditions were there, and these now are all included in IgG4 related disease spectrum. The disease is under recognized, and the reason for this is there is a lot of overlap between autoimmune disease versus non-specific inflammation, and the diagnosis requires aggressive multispecialty approach. Coming to the epidemiology, the current disease burden is more in USA with incidence of 1.39 per 100,000 person years, while in Japan it is 0.28 to 1.08, and incidence of autoimmune pancreatitis is around 3.1 per 1 lakh population. Based on the presentation of disease, there is a certain propensity for IG4 related disease that has been shown in young females, like they present with more of a head and neck related diseases of salivary gland and the lacrimal glands called as Mikulicz pattern of disease. While in elderly individuals, males, the other phenotypic patterns have been described, like autoimmune pancreatitis, sclerosing cholangitis, retroperitoneal fibrosis, and aortitis. Mortality is 2.5-fold increased in USA, while it is 2.1-fold in UK. So what are the factors that are contributing to increased mortality? So the patient will land up in end organ damage, the patient can land up in malignancies, and the patient can land up in infections and cardiovascular diseases due to prolonged glucocorticoid usage. So what are the malignancies that are commonly seen? So the malignancies because of autoimmune pancreatitis, we see pancreatic cancers, and because of the increased sclerosing cholangitis, we can see the biliary tract cancers. And of course, lymphoma and paraneoplastic syndromes have also been documented in IgG4 related diseases. So this is the current disease burden in the year 2024. The statistics say that total of 149,000 patients have been documented till date. And among these, the major disease burden is shown by USA and then followed by UK and Japan. Among the gender predisposition, of course, males are more predisposed, like 2:1 ratio of male is to female is there. And the mean age group of identification or diagnosis of this disease is 75 years. So it is most likely disease of elderly, and this data was given in Japan. So coming to the pathogenesis, currently no environmental and genetic risk factors are clearly associated with IgG4 disease. But recent studies have shown, like this is the largest clinical trial which was done on 850 patients, Japanese patients, where they have identified two specific gene loci. So they are now, the studies are focusing on HLA-DR-B1 and FC gamma receptor 2B. So it is giving a hint that there can be some association with these gene loci to be looked into future. Before heading to the pathogenesis, I would like to show your animated videos so that we can have better understanding of the humoral response that is going on for the antigen presenting cells. So this is a video depicting lymph node with the artery and the vein and the afferent lymphatics and the efferent lymphatics. So the lymph node is covered by the capsule, the superficial cortex, and the medulla. The white part is the medulla, and the greenish part is the T cell zone. This is the parafollicular zone, which is filled with T cells. The follicular zone is filled with B cells, and the medullary sinuses, which drain out through the efferent lymphatics. So T and B cells, they enter the circulation through the artery. Once they enter the lymph node, they go to their respective zones, T cell zone and B cell zone, through the high endothelial venules. And within the lymph node, there is a reticular network that is maintaining the architecture of lymph node as solid. And these cells just slide through this reticular meshwork, which is a very micro network. And here the antigen presenting cell, the dendritic cells, these are the dendritic cells with pseudopods. They present the antigen to the lymphocytes. And this is how the antigen presenting cell enters the lymph node through afferent lymphatics, then go through the paracortical sinuses and drain out through the medullary sinus. Now, once they have the antigen, when they are exposed to some antigen, they enter the parafollicular T cells, also called as paracortical T cells. So this green area, which is the parafollicular area, where there are T helper cells. So these dendritic cell activate the T helper cells to produce further response. So once the cells have been activated, yes, this is the continuation, another video showing the antigen presenting cell engulf, the antigens engulfed by macrophage, and antigen is displayed to the T helper cells. So what is happening here? The T helper cell, by the release of interleukin 1 from the macrophage, gets activated. And then in reverse, it releases interleukin 2 that will bring the army of B cells and the T cells. The cytotoxic T cells will proliferate, and the B cells will also proliferate to release the immunoglobulins. So this is a depiction of normal cell, which once taken up, when the antigen is taken up by the cell, it presents as an antigen presenting cell to the cytotoxic T cell, and they will initiate the process of destruction of the cell through granzyme and perforin secretion and cause lysis of the cell. So now how is the humoral immunity going on? Like the B cells, when exposed to the antigen, yeah, they sensitize the T helper cell. Now the B cells start proliferating into the plasma cell. These, at this stage, everything is going on in the parafollicular area. So this T helper mediated activation of B cell is going on in the parafollicular area. And once these plasma cells are released, they enter the germinal center, and the follicular T helper cells, which are there in the germinal center, also now mediate the class switching of the antibodies. Now, at this stage, now here the antibody generation, which is happening at a massive level, this is called class switching, and the selection of immunoglobulin. This will be taking place in the germinal center. Comes in the pathogenesis of IgG4 related disease. In IgG4 disease, the class switching is very selective, and only IgG4 antibodies are, most of the IgG4 antibodies are produced, while a few IgG1, G2, G3 also will be produced. But most of the antibody that is produced is IgG4. So the proposed mechanism that says is that there are two pathways going on here. So as we have seen in the parafollicular areas, what is happening? T helper cell, once they are presented by the antigen presenting cells, they get activated, they cause initial B cell interaction, and then plasma cells are proliferating. And once these plasma cells and the B cells are proliferating, they enter the germinal center. Now here happens the class switching. So in the germinal center, the follicular helper cells will activate more B cells to produce selective isotype switching. So IgG4 immunoglobulins are produced here, and these are retained as memory B cell and also as plasma cell, and come out of the germinal center into circulation. So, what are the factors causing IgG4 class switching? The proposed hypothesis says that there is some clonal CD4 CTLs. So, what the immunologists have shown that in IgG4 disease, there is a clonal proliferation of CD4 positive cytotoxic T lymphocytes. Normally, the cytotoxic T lymphocytes will be CD8 positive, but few of the CD8 positive cells are showing CD4 positive as well. So what the hypothesis says is because of the activation of CD4 positive CTLs, this is one of the reason for the class switch to IgG4 selectively. The other reason is the German center T follicular helper cells which are there. These are also responsible for selectively class switching to IgG4. Now we are not aware currently, but in coming years we might differentiate these follicular helper cells which are there in the German center to be some specific type that are causing IgG4 increase. So the main mechanism is because of CD4 CTLs that are increased. And these CD4 CTLs, they act both as a cytotoxic T cell, causing release of perforin and granzyme, thereby causing lysis of the cell and then replaced by the reticulin and fibrosis. In addition, they are playing a role in causing fibrosis by elevating the levels of interleukin 1, interferon gamma, and TGF beta. So this special mechanism is seen in IgG4 disease. So, and this similar pathway is now being tested for other autoimmune diseases. Like in systemic sclerosis, also researchers have found this similar kind of mechanism. And this is responsible for extrapolated fibrosis in these two conditions. So, the reason for extensive fibrosis is because of the CD4 CTLs. While in allergic conditions, it is a T helper 2 cell mediated reaction wherein there is activated macrophage that is causing TGF beta and causing fibrosis, and also T helper 2 cells by release of interleukin 4 and interleukin 13, they are causing fibroblast activation. So coming to the clinical manifestations, so the disease is multi-organ associated. It presents with the symptoms present depending upon the organ of involvement. Like the earlier nomenclatures which were there are being replaced by the IgG4 related terminologies once these have been diagnosed recently. So the type 1 autoimmune pancreatitis has been replaced by the term IgG4 related pancreatitis or IgG4 related pancreatic disease. And there is from primary sclerosing cholangitis, the subcategorization has been done to IgG4 related sclerosing cholangitis. The Mikulicz disease is now termed as IgG4 related dacroadenitis and sialadenitis. Similarly, the Kuttner's tumor has been replaced as the IgG4 related submandibular gland disease. The inflammatory orbital pseudotumor has been replaced as IgG4 related orbital inflammation. The dacroadenitis, chronic sclerosing dacroadenitis, is currently termed as IgG4 related dacroadenitis. And similarly, idiopathic retroperitoneal fibrosis or the hormone disease is labeled as IgG4 related retroperitoneal fibrosis and IgG4 related mesenteritis. And chronic sclerosing arteritis and periarteritis are currently called as IgG4 related arteritis and periarteritis. So similarly, radial thyroiditis, which were earlier called, is now called as IgG4 related thyroid disease. And apart from this, there is lung involvement where the current labeling of nomenclature is IgG4 related respiratory disease. In kidney, it presents as tubulointerstitial disease and membranous glomerulonephritis. CNS involvement has been shown as IgG4 related hypophysitis, pachymeningitis, and midline destructive disease. Coming to the clinical features, most commonly the organ involvement is around seen in 60 to 90% of cases, and about nearly half of the cases show asthma or allergy symptoms, and peripheral eosinophilia is seen in few cases. There is notable weight loss of 9 to 14 kgs seen over months, and this has been documented in multi-organ disease. And there is increase in serum IgG4 levels, and it is seen in 70 to 80% of the cases. while around 20% cases can be showing IgG4 normal levels. Now, the complement level is low in about half of the patients. So the reason here is why there is low complement is because of the binding of the remaining IgGs which are there, the IgG1, G2, G3, which are slightly also increased. So these bind to the complement and gets deposited in the kidneys and other organs. So this is a largest clinical trial that was done from a Japanese study, and they have shown that there is some phenotypic variation of presentation of cases in IgG4 depending upon the organs involved. And they have proposed 4 different phenotypes: the pancreaticobiliary type, the retroperitoneal or aortitis, the head and neck limited, and the mucolytic or systemic type. So, and it has been shown that young females have shown more cases with head and neck involvement, while the elderly males were showing the other patterns of involvement. And IgG4 was not much elevated, was slightly elevated or normal in retroperitoneal aortitis or retroperitoneal aortitis, while the IgG4 was markedly increased in the systemic or the mucolytic phenotype. And IgE was slightly increased in pancreaticobiliary and head and the systemic. ESR and CRP were mildly elevated in the retroperitoneal subtype. So one more advantage in categorizing is that there was better disease outcome in pancreaticobiliary and the systemic phenotypes, while the retroperitoneal and head and neck were showing treatment refractoriness because of the increased fibrosis. And the clinical features of IgG4 depend upon the organ involvement. When there is pancreas involvement, the patient present with diabetes mellitus and malabsorption due to exocrine insufficiency. And when the biliary tract is involved, they present with biliary stenting, infectious cholangitis, and hepatic failure. When there is aorta involvement, the patient present with aortic aneurysm. When there is pericardial involvement, patients present with constrictive pericarditis. Renal atrophy and chronic abdominal pain syndrome have been reported in retroperitoneal involvement. When there is orbital involvement, the symptoms would be like proptosis, vision loss, and diplopia, and cranial nerve paralysis when meninges are infected. So the diagnosis of IgG4 related disease require multi-systemic approach. There has to be a strong multidisciplinary team to diagnose the clinical features and correlate with the radiological and serological and pathological features. So the diagnosis of IgG4 is very challenging. There is because there are differential diagnoses to be considered when there is elevated serum IgG4. So serum IgG4 can also be elevated in few of the conditions which are enlisted here, like amyloidosis, atherosclerosis, cholangiocarcinomas, Erdheim-Chester disease, giant cell arteritis, Graves' disease, lymphomas, interstitial lung disease, renal cell carcinomas, sarcoidosis, and Sjogren's syndrome. There is no specific single marker for definitive diagnosis. So the Japanese multidisciplinary team has proposed a criteria recently in 2020, stating the clinical and radiological criteria where one or more organ has to be involved. The serological criteria suggests more than 135 milligram per deciliter as the IgG4 serum levels. The pathologic criteria suggests any 2 of the 3 findings has to be there. Dense lymphoplasma infiltrate with fibrosis, IgG4 plasma to IgG cells ratio more than 40% on immunohistochemistry, and IgG4 plasma cell more than 10 per high power field. And the third criteria postulated is typical fibrosis, that is storiform fibrosis or obliterative phlebitis. So any of the 2 findings are there, then it should be considered as pathologically significant criteria. Similarly, the American College of Rheumatology and European League Association have proposed a criteria for organ involvement in depending upon the organs. Like in kidney, the low complement levels have been given a score of +6. Renal pelvis thickening has been given as +8. Bilateral cortex involvement has been given as +10. So all these scorings has to be more than 20 to call it as a, diagnostic of IgG4 related disease. So similar criteria in pancreas and biliary tree, where there is diffuse pancreatic enlargement, score of +8 is given, and diffuse pancreas enlargement and capsule like a rim has been given as +11, and pancreas and biliary involvement is given as +19. So what should be the lab workup when we are suspecting a case of IgG4? Initially, we have to go with ESR and CRP. They will be mild to moderately elevated. If they are drastically elevated, then we should rule out the other causes like vasculitis. And we should do the anti-neutrophil cytoplasmic antibody and other vasculitis markers, so that we need to rule out vasculitis and multicentric Castleman disease. In CBC, we see mild elevation of eosinophil, and serum IgE will be increased in 30% of cases. As mentioned earlier, IgG4 is elevated in 50 to 80% of the cases, and biopsy from these lesions with immunohistochemistry for IgG4 has to be done. And when do we get a hint that there is some renal involvement? When are we seeing a subclinical kidney involvement? Is when there is a decreased serum C3 and C4 levels. So this is happening because the other IgGs are getting deposited in the tubular basement membrane and the glomeruli. So before coming to the final diagnosis, we have to rule out the other specific autoantibodies like ANCA, anti-SSA, Rho, or anti-SSB, LA, the double-strand DNA, the anti-SM, and other specific autoantibodies. So when all these features are met, all the criteria are met, the diagnosis is given as definite IgG4. When there is no elevation of IgG4, the diagnosis of probable IgG wording has to be taken. So I will just discuss 3 organ involvements because of the time constraint. So in IgG4 pancreatitis, the diagnosis is really difficult because we see a lot of overlapping here. The first overlapping is that IgG4 values will be more than 2 times the upper limit, but the IgG4 can also be increased slightly in pancreatic carcinomas. And here, positivity for autoimmune markers are common, like some ANAs are positive in 40% of cases, and anti-carbonic anhydrase antibodies are positive in 55. Similarly, the other antibodies are also elevated in pancreas. So here the big problem comes is the biopsy has to be taken simultaneously. And one more contrasting feature here is IgG4, though IgG4 disease in pancreas doesn't show elevation of CA19-9, but few cases have been documented to show elevation of CA19-9. So there is a diagnostic overlap between neoplasm versus infection versus inflammation and autoimmune disease when we are looking at autoimmune pancreatitis type 1. So these are some of the clinical scoring systems proposed for diagnosis of pancreatitis. So the classical feature of the sausage-shaped pancreas will be depicted in the CT scan. And this is the CBD dilatation. On gross, we can see the fibrosis and periductal fibrosis of the pancreatic head with extension of fibrosis to the duodenal wall. And microscopy, we can see the classical storiform pattern with the dense lymphoplasma infiltrate. So the features of obliterative of IgG4 pancreatitis, the classical obliterative phlebitis, we can see the destruction of the vein with the plasma cells and obliteration of the vein lumen. demonstrated on the elastic stain. We are seeing the weakening of the wall or destruction of the wall of the vein, and the IgG4 cells showing positivity more than 30%. Similarly, IgG4 related sclerosing cholangitis is distinct from, it has to be noted that it is distinct from primary sclerosing cholangitis, and it is most common extrapancreatic manifestation of IgG4 related disease, and seen in around 70% of the patients. The combination of biliary tract and pancreatic disease is diagnostic of IgG4 related disease. So when we see biliary tract involvement along with the pancreatic disease, when we are having suspicion for inflammation versus other causes, we should think first of IgG4 related disease. So the diagnosis in lymph node is really difficult because there is a parafollicular expansion of plasma cells in the initial stages. So on histopathology, it is extremely difficult to diagnose. But with expertise, we can do immunohistochemistry and we can get to a conclusion. So lymph nodes are involved in 40 to 60% of the cases. And in the later stages, we see the fibrosis and increased IgG4 positive plasma cells. There is no predisposition to any particular group of lymph nodes. So in lymph nodes, because the parafollicular cells will show, parafollicular area will show plasma cells, the criteria here is given as more than 100 plasma cells per hypoic field on immunohistochemistry. Similarly, IgG4 to IgG ratio should be more than 40%, which is universal throughout. These are a few of the images from lymph nodes showing the marked fibrosis and the parafollicular expansion by the plasma cells and lymphocytes. And on doing immunohistochemistry with IgG4, we can conclude the diagnosis. These are few of the images from renal involvement of IgG4 disease. The pattern in kidney is tubulointerstitial and membranous nephropathy pattern. We can see the within the tubulointerstitial pattern, there is a storiform. This is suspicious of storiform fibrosis. Now, on doing special stain, we can make out there is some storiform pattern. And the CD138 marker for plasma cell can be used to show the positivity of plasma cells. Further, electron microscopy can confirm the diagnosis. This is from the tubular membrane, where the granular deposits are seen in the basement membrane. And this is from the glomerular basement membrane. This is the glomerular basement membrane, and this is the subepithelial deposits which are seen on electron microscopy when there is glomerular pattern of involvement. And we see the mesangial granular deposits also in IgG4 related disease. So immunofluorescence can also document the conformation of IgG4 on tubular membranes and the glomerular membrane. So coming to the treatment strategies, most of the cases respond to steroid, basically with prednisolone 40 milligram followed by slow taper dose. Those cases which steroid is contraindicated has to be followed with azathioprine and mycophenolate. And whether to add rituximab or not, it has to be decided based upon the response of these treatment strategy with steroid. If the patient is not responding with steroid and there is multi-organ disease and markedly raised IgG4 levels, then we can go ahead with adding of rituximab. Surgery is indicated when there to just debulking for mesenteritis, and when there is a need for aortic aneurysm repair, biliary stenting, and relief of hydronephrosis. So the clinical trials which have shown response to rituximab, this is one of the clinical trials that has shown a drastic clinical response within 1 month of period. But the plasma IgG4 levels will not come down immediately. Throughout the course of disease, they may not come to the baseline. So, and to see the initial drop, it takes nearly more than 50 days. The reason behind this is the T half of IgG4 is around 28 to 30 days. So we will document any change if we want to see in the plasma levels. It will come after the 50 to 60 days. And after the rituximab therapy has been started, what happens to the B cell population? It gets drastically declined. Like after 30 days, they're completely declined. So what happens to the CD4 CTLs now, which are causing the increased selection or class switching to IgG4? CD4 CTLs are not much decreased. There is slight decrease from 21% to 15% after a period of nearly 3 months. So they still persist, and that's the reason why the patient has to be on maintenance therapy for long. So this was one of the article which I found interesting, where they have shown a course of a patient, how they present and how much years it took for them to diagnose, and how the importance of multidisciplinary approach is required for diagnosing IgG4 disease. As we can see, this one case which they have documented presented to them in from 2000, and after as autoimmune thyroiditis. Then slightly after a few years, the patient developed conjunctivitis and some endocrine symptoms, and orbitopathies like photophobia, diplopia, and they had to go with neurologist, ophthalmologist, endocrinologist opinion, but nothing confirmed diagnosis came up. Then after a couple of years, the patient presented with weight loss, pain abdomen, and other symptoms. So they labeled it as autoimmune pancreatitis and sialadenitis. And here the multidisciplinary approach was required from gastro, rheumatologist, and urologist. And furthermore, after a span of 18 years, IgG4 levels were done, like it was confirmed, and they started on prednisolone, and the patient was on remission with maintenance therapy after 2 years. So this is just to show how long, because of the multi-systemic involvement, it takes multidisciplinary approach and prolonged interval to come to a final diagnosis. So similar challenging case we faced in Bahrain Specialist Hospital recently, and I would like to show this case. The case which we encountered is a 58-year-old female. She was a housewife, non-smoker, non-alcoholic. She complained of pain abdomen, left-sided, hypochondriac with disturbed sleep. There was slight loss of weight of 3 to 4 kgs, no history of fever. The bowel movements were regular. There was okay.
Weight loss, quite weight loss.
Okay.
So the illness preceded 2 years.
Okay. So the bowel sounds were regular, no blood or mucus was in stool. And there was history of shoulder joint effusions bilateral, and the patient underwent arthroscopies twice in other hospital, but no confirmed diagnosis was made till now. And after evaluation with CT scan here, CT scan contrast showed a suspicious infiltrating mass with irregular borders, which was pushing or enrolling the jejunum and the colon. And we went ahead with biopsy and a multidisciplinary approach headed by a team of gastroenterologists, rheumatologists, gastrosurgeon, and radiologists and pathologists. And it was under the multidisciplinary approach and guidance from clinical expertise of Dr. Najazani, we could come to a final diagnosis of IgG4 disease. So the microscopic features which were seen were, there was a lot of fibrosis in the core biopsy, and in addition, there were areas which were showing storiform kind of pattern. We can see a storiform. So yes, ma'am, the whirling kind of pattern. And there was dense lymphoplasmacytic infiltrate, and there were some destruction of vessels, few extravasated RBCs, and vessel lumina was completely obliterated, and there was classical obliterative phlebitis kind of pattern with the vein collapsed, with veins with collapsed lumina and the wall showing the damage of the wall. So these are the findings which were seen, and we went ahead with IgG4 immunohistochemistry, and it was more than 35 per high power field. And IgG was also done to see the IgG4 to IgG ratio on immunohistochemistry. It was more than 40%. So to summarize, IgG4 disease is a systemic immune-mediated fibroinflammatory condition manifesting as mass lesion with chronic lymphoplasmacytic infiltrate, increased IgG4 plasma cells, obliterative phlebitis and storiform fibrosis, serum IgG4 levels elevated in nearly 70% of the cases, and biopsy will show IgG4 elevation on immunohistochemistry. Incidence is more in USA compared to UK and Japan. Mean age of presentation is 60 to 70 years with multi-organ involvement seen most commonly. Symptoms of asthma allergy are seen in 40% cases. Weight loss is seen in patients with multi-organ involvement. So the treatment strategies include steroids, followed if contraindicated, has to be moved on azathioprine and mycophenolate, then plus or minus rituximab. And the response with rituximab has been shown to be 80 to 90%. So still few questions that are unanswered and has to be dealt in further coming research. Is there a genetic background implicated in IgG4 related disease? So currently no established data is available. I hope in few decades it will be revealed. Is there any infectious organism or environmental or any autoimmune trigger that is leading to this disease? So this also data has to come up. And are there any specific biomarkers available currently? No, as of now, there are no specific biomarkers, but the multisystemic and multidisciplinary approach can help us. And biopsy confirmation with immunohistochemistry of IgG4 and the IgG4 to IgG ratio can help us in coming to the diagnosis. Now, whether the phenotypic classification, which was proposed by the largest clinical trial, whether it affects the patient management, therapeutic strategies, and prevention of disease-related morbidities. Similar data has to come up from multiple clinical trials. So the disease is still under research from etiopathogenesis to management level. Thank you.